Welcome back to Balanced Health. Men always have questions about their health, and Dr. John Plant is here to address some of the issues that our male viewers have written in and called in about. But first, we have a couple of questions that we wanted to ask you, and we'll continue with our discussion. Very good information, by the way, last time you were on with us. It was great.
Thank you.
Did you have a question, Joe, about?
Well, I think that one thing we want to address right away is that this isn't a show for men only. There are so many women who their husbands won't ask these questions.
That's
They won't go there. It's just like the
right.
direction thing, right? They're not going to ask the doctor. I mean, most men do not want to go up to the doctor and say, doctor, I'm having a problem with my romantic life with my wife. Let's talk about impotence. Let's talk about infertility and the ultimate erectile dysfunction word.
Yeah, because we read about it in the newspapers every day, so why not? Let's talk about it.
Excellent questions. Extremely common. You know, the sales of Viagra are off the chart, and Levitra and Cialis. Likewise, this is a huge industry in this country, and the reason it's a huge industry is because there's a huge demand. And as the population gets older, erectile dysfunction becomes part of the landscape.
And yet boomers are in denial about everything regarding aging, so why not that too?
And we have an epidemic of diabetes in this country, as you well know. Hypertension is certainly very common, and those are the two biggest factors leading to erectile dysfunction. So,
really, diabetes and high blood pressure.
Absolutely.
When you talk about ED, Doctor, can you clarify something? Because I think most people have this question. The difference between ED and I would just like the experience to be that much better.
The strict definition of erectile dysfunction is the inability to penetrate and have intercourse, if you want to boil it down to the purest definition. Now, obviously, that encompasses a certain group of people, and then there's another group of people that might even be larger that has something less than that, where the satisfaction issue comes into play. Exactly.
Or occasional dysfunction.
Exactly.
But you wouldn't call a person impotent if they just had problems. Yes.
Exactly.
How do you feel as a physician prescribing the drug when it is just a stamina or satisfaction issue? I'm sure there's other factors you look at, you know, like blood pressure and whatever, if the patient's at risk in other areas. But if he's not at risk in other areas, you're comfortable with that?
Yeah, I'm comfortable with it. You know, as long as they understand the risks. All medicines have risks. People need to know those risks to safely prescribe them. As long as there's no contraindication to using the medicine, and if it makes somebody's life more enjoyable, then I'm all for it.
You know, there's a big hullabaloo in the newspaper not too long about that Viagra causing blindness and things like that. Are these drugs safe?
Yes, they are safe. If we look at worldwide Viagra usage, you know, it's off the charts. And what happens is you're going to have a couple of people in any large group that may get some disease process, such as macular degeneration, or have a stroke, or have a heart attack. And the question becomes, is the Viagra causing it, or it just happens to be that sample size is so huge that in a natural occurring population of people, you're going to have so many people that go blind over the course of a year. So there's been no conclusive proof that Viagra is causing blindness.
And Viagra originally was a heart drug?
Well, they started looking at Viagra exactly because it lowers central blood pressure, and that's one of the risks of Viagra, especially in people that have heart disease and use nitrate drugs, especially for angina. So the two medicines acting together in concert can cause a disastrous drop in blood pressure, which then leads to heart attacks, and that's why those people should not be on Viagra. But you're right; it started out in development as a cardiac drug.
Well, one of our viewer questions is they talk about the fear of seeing a urologist because of some of the procedures that you read about online. One of them, and I might be mispronouncing it, I want to forget how it's pronounced because I had one done, cystoscopy.
Correct, yeah.
I'd like to use the word ow. I'd like to use the word, I hope I never have to do that again. That was the single worst 15 minutes of my life. When is intervention? Oh, it was... We can't talk about it on the air, but it was a nightmarish experience.
Yeah, right. And you guys should have to get mammograms up.
But I knew she'd bring that up. But I guess my point is, and this viewer's point is, I didn't expect that type of intervention. You know, when I went on there, When do you intervene? You see what? You see a high PSA. We talked about that. What else might you intervene? So the guy's got blood in the urine, or what? Well,
for other urologic interventions, obviously blood in the urine, a nodule that's felt on a physical exam of the prostate, that would cause us to want to ultrasound the prostate. Cystoscopy, of course, is used for the evaluation of a lot of things, such as blood in the urine, other conditions of the bladder and urethra, people who have different voiding difficulties, we may want to take a look in there. And you're right, it's not something that you'd want to go have done every day of the week.
Did you figure something else out? There's got to be some way you could do an MRI and not have to go through that situation.
If you come up with it, you let me know.
I would have to be doing this show for a living, right? Go ahead, Shirley, please.
There are a lot of different issues that men have. I mean, not just the prostate. I mean, colon cancer is a huge killer as well. And we may. This was a viewer question. I just have to ask you this: Is what about male menopause, and does it exist?
That's a good one.
In the traditional sense of the word, no. But as men get older, they lose some of their testosterone production capabilities. And that can happen at various ages in different individuals. And as their testosterone production goes down, they in fact start to experience diminished libido, or their sex drive goes down, muscle mass can decrease, overall energy can go down, and they can get a type of osteoporosis from lack of testosterone. So
really?
Yes, it's not the same, but there are shared similarities.
There are some symptoms.
When that happens, do you give testosterone?
Absolutely. If we have to, and if someone's suffering, their libido is low and their serum testosterone is inappropriate for them, then we can augment that through a variety of ways.
Are there any dangers to doing that?
Well, you have to be very careful with somebody that has a predilection towards prostate cancer, strong family history, someone who has a lot of other prostate issues. You might be careful about administering exogenous testosterone, but for most people, it's quite safe.
Good, because prostate cancer does feed on testosterone or something, right?
Testosterone is the fuel, exactly.
Okay.
Another viewer question here is talking about, they said the latest and laser treatments. I don't know exactly what they mean by laser, but certainly on the latest treatments. You hear about this treatment for prostate cancer with the seeds being more direct, a smarter, that's not actual chemotherapy. Is it chemotherapy?
No.
No, it's actually, aren't you injecting radiation into it?
Radiation, that's what I'm sorry.
Yeah.
Yes.
Basically, it's called brachytherapy, and what is involved is that these little pellets that are radioactive, and there can be different elements with different half-lives, are actually implanted within the prostate. Those seeds then self-destruct over a certain time period and deliver the radiation to the limited area in the prostate, enabling you to direct the treatment where you want it, not have to deliver it externally.
Right, with all the peripheral damage.
Correct.
Okay.
And has this been helpful? I know that years ago, getting a diagnosis of prostate cancer in your 40s was maybe not a death sentence, but probably fairly close. Is this being used for? Is it helping people that are getting diagnosed with this earlier? Is it for all cases, I guess is my question.
It's not for all cases. And, prostate cancer there's not one, solution fits all. You have to individualize these cases. Everyone is different. Everyone needs to be assessed for themselves, not as any type of group. So, no, you don't put radioactive seeds in everyone, nor do you do surgery on everyone, nor do you give external beam radiation to everyone.
Should you avoid the removal of the prostate if at all possible? I know I've heard it's a horrible surgery. My husband did not have his prostate removed, but I've heard it's pretty bad.
Well, a lot has been accomplished in the last 20 years, especially now with robotic prostatectomy becoming more and more popular and more available across the United States. We're talking about recovery times that are down to 2 or 3 days and postoperative pain that is very, very manageable. So these issues, I think, are going by the wayside. And there are certain people that really do benefit from surgery, especially the younger patients, because they have long life expectancies.
Right. And then you get rid of the cancer.
And the risk of recurrence is always something that they have to think about going forward.
Well, this has been great, and it's very important information. And if you have any health questions, why don't you email them to us at balancedhealth@tln.com. And for more information, visit www.tln.com, our website, and then click on shows, and then go to Balanced Health. And also remember to call this number, 888-242-9393, if you'd like a copy of today's show. And we'll be right back with our healthy habit of the day, so stay with us.
Don't want to miss that one.